Good evening, everybody. It's Katie Pryor here from the Western New South Wales PHN. Thank you all so much for joining us for our COVID-19 update on long COVID. I would like to start tonight's meeting by acknowledging the traditional owners and custodians on the lands on which we all meet tonight. I pay respects to all First Nations people and acknowledge elders past, present and emerging, and recognise their continuing connection to land, water, culture and community. I extend that respect and warmly welcome all Aboriginal and Torres Strait Islander Australians who are present tonight. We thank you all for joining us. I'll just move on to a little bit of housekeeping before we introduce our presenters. Tonight's meeting is being recorded, so any colleagues that weren't able to dial in, if anyone misses a bit, we will send the link around and you can catch up on that. Everyone is also on mute. That's to optimise the sound quality. We do encourage your questions though, so please pop those into the questions panel in your control pane, and we will get to those questions at the end of Professor Dore's presentation. If you are phoning in tonight, if you could please email us at cpd@wnswphn.org.au, just so that we can record your attendance. And now I would like to introduce our GP facilitator tonight, who is Dr. Ai-Vee Chua. Ai-Vee is the GP with Dubbo Family Doctors and the Rural Co-Chair of New South Wales Health's COVID-19 Primary Care Community Practice and Clinical Editor for Western New South Wales COVID-19 Health Pathways. And I'll hand over now to you, Ai-Vee, to introduce our presenter tonight. Thanks, Ai-Vee.
Thank you, Katie. Thanks everyone for joining us this evening on our next episode of COVID in Western New South Wales, and tonight we're focusing on long COVID. We're delighted to be able to say that we've got Professor Greg Dore joining us this evening. Greg is Head of Viral Hepatitis Clinical Research Program at the Kirby Institute, UNSW Sydney, and ID Physician, St Vincent's Hospital, Sydney. Professor Dore has been President of the Australasian Society for HIV Viral Hepatitis and Sexual Health Medicine. He's a member of the NHMRC Council and is an NHMRC Practitioner Fellow. He's also a member of the Australian Academy of Health and Medical Sciences, and Prof Dore has been involved in the COVID-19 response, and I think most of us would have had the privilege of reading Prof Dore's information on various articles. And he's also been the chief investigator of the post-COVID ADAPT study. We're also fortunate tonight to have Dr. Sumitha Gounden from the Orange Health Service join us. Sumitha is the Rehab Medical Head of Department at Orange Health Service. She's also a clinical lecturer at Sydney Uni Medical School of Rural Health and an adjunct senior lecturer on School of Rural Medicine, Charles Sturt Uni. And last but not least, fellow GP, Justin Gladman, who's currently working with the RFDS based in Broken Hill. He also works in the local hospital there in the emergency department and is a senior lecturer with Adelaide Uni Rural Clinical School. Prior to medicine, Justin had experience in research management and also spent time in the Army. So thank you very much to all our speakers tonight. So I'll pass over to Greg now at this stage to take us through the presentation on long COVID. Thank you, Greg.
Thanks very much, Ai-Vee. Can you hear me and see the screen?
Absolutely, it's perfect.
Great. Look, thanks very much for the invitation to present. Firstly, I'm coming to you from Gadigal country in the eastern suburbs of Sydney, and I'd like to pay my respects to elders past and present. So I'm going to try and give you an overview of long COVID in the sort of 25 to 30 minute presentation, and then hopefully we'll have a really nice time after that to go through questions with the panel. In terms of the areas I'll be covering, I'll talk about definitions of long COVID, the spectrum of long COVID illnesses, initial investigation and management, talk specifically about the ADAPT study at St Vincent's Hospital that Ai-Vee mentioned I'm a chief investigator of. We're specifically looking at neurocognitive impairment as well as a whole range of other measures, and also doing some interesting qualitative research. I'll talk about some theories in terms of immunopathogenesis as far as sort of underlying mechanisms for long COVID illness, and also touch on some potential therapeutic directions that we may take. Okay, so in terms of COVID, everyone's pretty aware that this has been a pretty interesting last couple of years in terms of public health and clinical medicine. Globally, there's over 500 million cases diagnosed, many more obviously undiagnosed. About 7.5 million deaths so far, but probably that's a large underestimate. Look at the situation in Australia, where the first case was diagnosed towards the end of January 2020. We've had really enormous number of cases, had higher testing rates, so have diagnosed, I think probably a large proportion of the infection. So 6.3 million cases, many of those cases occurring in the last several months with the Omicron wave. A bit over 7,500 deaths. And we're still running at over 40,000 cases per day and around 30 to 40 deaths per day, which just tells you the ongoing sort of burden in terms of severe disease and mortality. But we're here to talk about long COVID. As Ai-Vee mentioned, I'm an infectious diseases physician at St Vincent's. We've had a major role in terms of the pandemic, in terms of local response. Particularly, we've been involved in screening across many centres in Sydney, doing community-based screening as well as in the tertiary setting. So it's interesting to look at the overall case numbers in Australia, and it's pretty remarkable that the cases back in 2020, so early cases say in March and April 2020, don't even register here. Even the winter outbreak in Melbourne doesn't really register because of the enormous number of cases that we're now seeing with the Omicron wave, and even the Delta sort of wave that really caused quite significant morbidity and mortality in terms of case numbers, really hardly even looks like it's much of a wave there. That's because we've had this enormous Omicron wave where a large proportion of the population have been infected in the last several months. The death curve is somewhat different because we had these early deaths, and then this, as I mentioned, this large winter 2020 outbreak in Melbourne, and at that stage, obviously pre-vaccination, much higher case fatality rate than we see now. This is the Delta wave in terms of the deaths, and these are the Omicron deaths. So even though Omicron is probably intrinsically less virulent, and certainly because of vaccination, has a much lower case fatality rate because of the huge burden of cases that's sort of tracking through to causing significant morbidity and mortality. Just a little bit in terms of the initial natural history of acute infection. I think we're all aware that we have a pre-symptomatic phase that can last for a couple of days as the virus level increases. A relatively short viremic sort of period of about a week on average that can extend to up to 2 weeks in terms of that detectable viremic period. And this initial sort of viremia triggering an immune response, and sometimes a quite aberrant immune response in that acute phase. People talked about a cytokine storm in terms of really overactive immune response to the initial viremia. And then people obviously either developing mild, moderate illness, severe illness, or very critical illness. And the antibody detection generally by 2 to 3 weeks following initial infection. A little bit about Omicron, because it's all about Omicron at the moment. So clearly it's a variant of concern. It's the dominant variant this year. RO is the sort of infectiousness of the variant without any restrictions, how many people on average one index case would infect, and it's thought to be above 8. If we think about the original Wuhan strain, that was about 2 to 3, Alpha strain was 3 to 4, and Delta somewhere between 5 and 8. So there's been this progressive increasing infectiousness with the new strains that have come through. Interestingly, it does have a shorter incubation period, so the period from initial exposure to symptom onset is only on average about 3 days compared to Delta, which was 4 days, and the original strain 5 days. I mentioned that it does cause less severe disease, and that's probably for 2 reasons. One, because we're a highly vaccinated population in Australia, but there probably is also some intrinsic lower virulence in the Omicron strain versus the previous strains. There is lower vaccine effectiveness versus infection. The vaccines are still holding up pretty well in terms of protection against severe disease, but there's no doubt compared to the Delta waves, which if we remember back to what was happening in southwestern and western Sydney, where the rapid rollout of vaccination really helped turn around that wave of infection, the vaccines have a modest impact in terms of infection risk and transmission. And look, very few countries have escaped a major wave. China is obviously grappling with an outbreak in Shanghai after their large wave in Hong Kong. And unless you want to go down the pathway of draconian sort of measures, I think no country will escape a large wave of Omicron infection. The downside, obviously, of this large wave is that we get a large burden of acute morbidity, obviously significant mortality, and also some ongoing morbidity that we're talking about today. But the large number of cases does enhance our population level immunity. So we now have high level vaccine and infection-based immunity, so-called hybrid immunity. And this sort of population level immunity will, I imagine, lead to a sort of tracking down of the case numbers over the coming sort of weeks. We may get new strains, obviously, but I think the Omicron wave will start to subside over the coming weeks. This shows the case fatality rate. So if you recall back to 2020, in an unvaccinated setting, about 3% of diagnosed cases were dying. The testing rates were somewhat lower in 2020. Then we started to vaccinate from early 2021. The Delta wave sort of emerged. The case fatality rate dropped to around about 1%. And then the Omicron wave was upon us. Thankfully, with vaccination and the lower virulence, the case fatality rate dropped to about 0.1 to 0.2, so 1 to 2 per 1,000. We would have had an incredible burden of severe disease and mortality in or a poorly vaccinated sort of setting. We're very fortunate that we had particularly high rates of vaccination in the older age groups, very different to the situation as alluded to in Hong Kong and mainland China. Okay, so what about long COVID terms? The term long COVID or long haulers emerged in sort of May, June of 2020, and it really came from patient or community-based discourse around the effects that post-COVID illness was having. WHO have termed long COVID post-COVID-19 condition, and there's been a separate label post-acute sequelae of SARS-CoV-2, a bit of a mouthful, coming from the US CDC. But they all talk about ongoing illness following the acute period. So what is the acute period in terms of duration, and when does long COVID begin? And there's different definitions in terms of the duration. I think the acute period generally lasts a week or less. I mean, most people with Omicron, the median duration of symptoms is in fact around 3 days. Some people it goes on for longer than a week, into the second week. But most people, the large majority in fact with Omicron who are vaccinated, will have an acute illness that will last a week or less. And then we talk about long COVID in the context of symptoms that go on for more than 4 weeks as a first sort of definition. And then if it extends for 3 months, that's a very firm long COVID definition. So some have used a 4-week duration, others have used a 12-week duration. And there's a variety of symptoms and organs that are affected in terms of post-COVID illness. And I'm not going to go through them all in detail because I'll come back to them. And in terms of symptomatology, again, this enormous sort of range of symptoms that people report several weeks following the acute COVID illness. Fatigue is definitely the most commonly reported ongoing symptom, and that can sort of cluster around some other sort of symptoms here. Then you have a sort of cognitive type sort of cluster, headaches, anosmia, memory loss, anxiety, depression. I'll talk a bit more about anosmia and the relationship between anosmia and cognitive impairment from some of the data from our ADAPT study. And then you have sort of a cardiothoracic type symptomatology. So some people have breathlessness, some people have chest discomfort, some people have ongoing sort of cough. But many other symptoms are reported. Arthralgias, myalgias are sometimes reported as well. So it's sometimes very difficult to try and put all this together because of the diversity of the symptomatology. So in terms of specific definitions, I said persistence of symptoms for 4 weeks is sometimes called post-acute illness. And then if it extends for 12 weeks, long COVID is generally referred to. The prevalence varies enormously. The studies that have looked at this have been very heterogeneous. So there's been estimates ranging from 2% up to 37%. That's differences in study population and definition for long COVID. So it's not surprising that there has been this wide sort of range. It has frustrated some people because some people, I think, have overplayed the prevalence of long COVID. Some people have underplayed the prevalence of long COVID. There's been some really good studies coming out of the UK. They looked at age and sex matched control. So it's really important, obviously, to try and do studies where you have control populations. Because you ask 100 people any one day whether they feel tired or whether they've got a headache, and you'll get a proportion of people that will say yes and would fit a definition of long COVID based on symptomatology. But they found about 14% had long COVID symptoms, and obviously a couple of percent in controls. They've done some more recent studies in the UK looking at the estimate in individuals that are triple vaccinated with Omicron, and they estimate around about 8% reporting post-COVID symptoms at between 4 and 8 weeks. I expect that to drop off a little bit by 12 weeks. So look, maybe we're looking at a rate of long COVID symptoms through to 3 months of around about the 5% mark, I think. It would have been higher in the pre-vaccination, the pre-Omicron sort of era. Fatigue is the most commonly reported symptom that I've mentioned, and there's various other symptoms that I've talked about. Many patients describe a brain fog, and that can be a constellation of symptoms, including issues around attention, concentration, short-term memory. There's various predictors of long COVID. There's no doubt that the severity of the acute illness, so if you have severe acute COVID, you're hospitalised, you're more likely to have ongoing symptoms. That's not surprising, given people were so severely unwell in the acute illness. Female sex does seem to be associated. It's interesting, severe acute COVID is more likely in men, but long COVID, particularly in the non-severe group, is more likely in women. And there's several other factors: obesity, asthma, pre-existing poor physical and mental conditions, and vaccination status, clearly. But it's really important to highlight that younger people with mild acute COVID illness are also at risk. Their risk is somewhat lower, but we certainly do see people in their 20s and 30s who've had relatively mild acute illness developing long COVID symptoms. This is a study that was looking at the impact of vaccination on various markers. So vaccination, this is sort of 2-dose vaccination, reducing hospitalisation, as you may anticipate, but also reducing symptoms lasting for longer than 4 weeks by about a half. So this was double-dose vaccination, reducing the risk of long COVID, defined by symptoms going for a month, by around 50%. Triple vaccination, maybe even further. So I just wanted to move on to show you some data from our study at St Vincent's, where we've been following people from about mid-2020. We set up the study, and we have a large number of what we call first waivers that came through acute infection in March, April, were enrolled into the study. So we were keen to look at the natural history of long COVID, factors associated with post-COVID symptoms, explore potential immunological mechanisms for ongoing illness, characterise post-COVID neurocognitive function and mental health impairments, and also do some qualitative work. In terms of symptoms reported at 2 to 3 months, we really did have quite a significant proportion of symptoms, but this is any symptom. So even if you reported fatigue, you're counted as having ongoing symptoms. We did get referred some patients from elsewhere, so to speak, because we were starting to develop some expertise in long COVID. So that's why we've adjusted or looked at those that were just diagnosed through the St Vincent screening clinics. And there still may be some selection bias. It's important to acknowledge that in terms of these prevalence measures. And they're somewhat higher than I mentioned in the UK-based studies. But we found, around at least a third of people reporting symptoms at 2 to 3 months post-acute infection. And as you can see, a very small number of people with severe acute. This was the initial cut of the data. We've had further sort of follow-up. And then we divided the acute cohort into those that had mild acute and those that had moderate acute. And you can see that the key sort of symptoms, this is comparing acute to post-COVID symptom prevalence. But in terms of post-COVID prevalence, fatigue, shortness of breath, and chest discomfort or pain seem to be common symptoms that were reported. And they, as you can see, a bit more common in those with moderate acute versus those with mild acute, but still present, obviously, in those patients with mild acute COVID. We also had a range of patient-reported outcomes. This is more looking at trauma and psychological status with a range of different measures. The DMI, for example, is the depression in the medically ill in the green, and the severe is a measure that looks at both physical and psychological sort of well-being. And we really did have quite a significant proportion of people that scored poorly on some of these patient-reported outcome measures. And you can see that are quite significant proportions here reporting depression, and even in those that had mild acute illness, with 1 in 4 are reporting significant depression. In terms of lung function tests, we did standardized lung function tests on the majority, not all of our subjects. So these are just some initial cohort sort of measures. And even though many of the measures in terms of FEV and vital capacity were fine, we did see some abnormalities in terms of diffusion capacity, so DLCO. So in those with moderate acute, for example, you would expect this in severe acute COVID to have significant diffusion capacity at 2 to 4 months in terms of impairment, but we were seeing more than 15% of those who had moderate acute COVID still on formal lung function testing having some impairment in terms of diffusion capacity. So telling us that this is an interstitial disease that can lead to some impairment in terms of overall lung function. Okay, so moving on to whether long COVID recovers after 3 to 4 months or is sustained. Initially, I was pretty optimistic. I was sort of telling patients that I felt that most of them should be able to recover over the next sort of several months. So I was somewhat disturbed when this data came through, comparing how things were between our month 4 visit post-acute illness and our month 8 visit post-acute illness. And really not a lot of change. So in terms of the proportion reporting fatigue, still around about 20% were reporting fatigue at 8 months. Shortness of breath had improved somewhat, some sort of reduction, but still a significant proportion reporting shortness of breath. And then if you compared the overall reporting of long COVID type symptoms, no significant change. There's some people that recovered, some people actually had a relapse, so to speak. So they seemed to be pretty well at 4 months, but had symptoms present at 8 months. So this can be a somewhat sort of relapsing sort of illness where people go through phases of feeling reasonably well and then have a bit of a setback. Okay, so this is some interesting data. We did formal neurocognitive function testing with a tool called Cogstate. And we also did formal smell testing with a NIH smell testing battery. And we found, in terms of neurocognitive impairment, about 10% of people had significant neurocognitive impairment. And somewhat surprisingly, even though the number of people with severe disease wasn't very large, but pretty similar neurocognitive impairment across the different acute COVID severity groups. In terms of anosmia, in terms of formal olfaction impairment, you can see quite a significant proportion, including those with mild acute COVID, having olfaction impairment. And it's quite interesting that neurocognitive impairment was more common in those individuals that had olfaction impairment. So in fact, neurocognitive impairment in more than 20% of people that on the formal olfaction testing had impairment, versus only 4% in those that had no olfaction impairment. With the Omicron variant, it's interesting, we seem to see less anosmia, and hopefully that will mean that we'll see less neurocognitive impairment with this variant. Qualitative study, I'm not going to go into in any great detail, but just to say we have a great sort of qualitative researcher, Kari Lancaster, and collaborator Tim Rhodes. And they're in fact doing a series of qualitative interviews with a group of 30 to 40 participants have just completed, or they're just completing their third round of qualitative interviews. So they're talking to people out to 2 years post-infection now. And really sort of very sort of rich data in terms of the impact that COVID's had on their life, in terms of the interactions with healthcare professions, and just their experience and how they're sort of learning to sort of live with long COVID. So I wanted to go through a few aspects, and this was from a great overview piece, which looked at a number of recommendations and did a sort of consensus exercise in trying to come up with some recommendations. So published in the British Journal of General Practice last year. So just flicking through some of the main conditions, I'm not going to go through them all, but myocarditis and pericarditis is something that we're certainly seeing. Dysautonomy, including postural tachycardia syndrome or POTS, is something that we're seeing in some of our patients. There's been a lot of discussion about mast cell sort of activation. I haven't really seen much of that, but it's certainly been described. And thromboembolic disease is something that's getting quite a bit of airplay and it's creating significant concern. And there's some theories around sort of microclot formation and what impact that may have in terms of thromboembolic disease. We do see cases of new onset diabetes, and thyroiditis is also being described. In terms of recommendations relating to diagnosis or underlying disorders, again, I'm not going to go through these in detail, but you'll have these to go through with the presentation that'll be circulated. I think it's really important. I've been trying to sort of do face-to-face interviews with people. Sometimes you've got to do phone consults, but as much as possible, I think it's really important to have a face-to-face consultation with the patient with long COVID. And there's a range of different investigations that are considered a sort of battery of baseline investigations. So the general sort of pathology, looking at inflammatory markers such as CRP, looking at D-dimer, which can be elevated in terms of general inflammation, but also with thromboembolic disease, thyroid function tests, HbA1c because of the tendency for potential diabetes, then vitamin D, magnesium, folate, ferritin, and other measures that are routinely tested. We've talked about the lung function test. I just wanted to reiterate that be aware that simple spirometry may be normal, but patients may have diffusion defects indicative of scarring, chronic pulmonary embolisms, or microthrombi. So to consider referral to respiratory for full lung function sort of testing. And as I've shown you with the data from ADAPT, this can sort of show significant diffusion sort of deficits. In patients with chest pain, consider a referral to a cardiologist. We use cardiologists pretty regularly. because we do see cases of myopericarditis. We have been doing, the cardiologists have been ordering cardiac MRIs. We've done cardiac MRIs on a reasonable number of the ADAPT cohort participants, and we do find some that have evidence of inflammation and scarring on their cardiac MRI. Obviously, in patients with palpitations and or tachycardia type syndromes, they need to be sort of generally referred for specialist input. And then the other group in terms of specialist input is patients with cognitive difficulties and potential neurocognitive impairment. So we often refer patients to our neurologist, Professor Brew, is part of the ADAPT studies group, and he's been great in terms of overall doing long COVID care as well. In terms of management, general approach, I mean, I think one of the things that I've learnt in terms of caring for patients with long COVID is certainly not to try and get the patients to work their way through or exercise their way through the symptoms. And I think that can really sort of set patients back. So I think most patients really need to rest up, take a decent sort of period of time where they're really looking at self-care and not exerting themselves too much. So need to sort of emphasise the importance of initial phase of convalescence, followed by careful pacing and rest. And also, really supporting patients in shifting their mental timeline of recovery. So I think it is crucial to discuss that there's a very diverse range of how people recover. Some people will recover within several weeks, but some people, it will go on for months. And as I mentioned, we have patients we're still following 2 years following the acute illness. Now, I hope that those that are developing long COVID now in the context of being vaccinated, in the context of Omicron infection, may have a different trajectory in terms of recovery. And I'm hopeful that they may recover more quickly, but we don't know that yet. So there's still a lot of uncertainty out there. And encouraging reporting of sort of new symptoms, because as I said, things can be somewhat sort of relapsing. In terms of specific sort of conditions, I'm not going to go through this in detail, but just to sort of note, in terms of patients with cardiac symptoms should be advised to limit their heart rate, and really not to try and sort of exercise your way through this. And it's something that really requires careful sort of rehabilitation. In terms of POTS syndrome, there are some sort of preliminary measures that can be undertaken in terms of fluids and salts, compression, etc., and specific rehab. But sometimes patients will need to consider a beta blocker, of Abradine or fludrocortisone in terms of pharmaceutical intervention. And then there's clearly a need for respiratory rehab and breathing training for a subgroup of patients. We have a long COVID clinic at St Vincent's that is really targeted at respiratory rehab. That's been mainly looking after the severe acute patients that have been discharged, but sometimes you've got patients that have had relatively mild community managed acute COVID that do have ongoing breathing problems, so can be referred for specific respiratory rehab. And clearly there's a need for mental health assessment in a proportion of patients. It's very important not to overplay the psychological component. I mean, clearly many patients have seen healthcare professionals who sort of inferred at least that this is all in their head, this is psychological rather than a physiological condition. But there's a complex interaction between physical and mental health, clearly. But many patients, because of the physical disability and the physical effects of long COVID, will clearly have mental health strains and conditions that will need to be addressed specifically. Look, there's lots of potential long COVID therapies that have been looked at. There's nothing that's come through yet that's been adequately evaluated and demonstrated to be beneficial. And I think part of the problem is that this is a very diverse condition with probably diverse underlying immunopathogenesis. So I think it's very unlikely it's going to be one specific intervention that's going to be beneficial in terms of long COVID. There'll be sort of subpopulations of people with long COVID that may benefit from specific therapies. So turning to immunopathogenesis, the question is it one illness or several? I think it's more towards the latter. Is it a prolonged recovery from an acute viral immunological damage? Is it an autoimmune disorder? There's been studies evaluating autoantibodies. Is there ongoing inflammation or an immunological disorder? And people have talked about potential remnant viral antigens, so not active infection, so not ongoing replication of the virus, chronic infection, but remnant viral antigens. There have been some studies looking at gastrointestinal epithelial biopsies and finding remnant viral components that may be enough to trigger ongoing inflammation, but clearly it's complex. And this is some complex data from the ADAPT study, where we've looked at a range of different cytokines and other immune measures. And what we find is that in post-COVID, whether you have long COVID symptoms or not, you have an upregulated inflammatory cytokine response. And we've compared people post-COVID with and without long COVID to a group of patients that we had that had testing for SARS-CoV-2 for COVID, were found to be negative, but were positive for other coronaviruses. So we had samples taken from those, and we had samples also from completely healthy community controls as well. So we're finding these sort of elevated cytokine sort of levels in those with and without long COVID. But when we compared the 5 months to 8 months measures, you can see on some of these cytokines that those without long COVID were improving. So we had reductions in their levels of cytokine, type 1 interferons in particular, in those that didn't have ongoing symptoms of long COVID. But in those with ongoing symptoms of long COVID, you can see this sort of persistence in terms of elevation. So some, I suppose, some insight into the fact that this may be ongoing inflammatory response. Again, that opens the door to potential therapies. There may be immune modulating therapies, for example, that could be evaluated in terms of long COVID. And just finally, to acknowledge the team members for the DAP study, which is led by Gail Matthews, the head of ID at St Vincent's, and David Darley, a respiratory physician, Bruce Brewer here, who's doing the neurocognitive work, and a large team of research assistants and clinical nurses. So thanks very much for the opportunity to present, and it'd be great to have an informative and interactive discussion.
Thank you so much, Greg, for that presentation. We do have a question that's popped up in our question and answer box, which is in relation to therapies for long COVID. You showed us a slide where several pharmacological therapies are being trialled, but has there been any natural or nutritional therapies that have been shown to be of value?
I know there's a lot of patients that take alternative therapies. A lot of patients are on multivitamin complexes. Some people are on vitamin D and vitamin B and selenium and zinc, and a whole range of those alternative therapies that have been utilised at the individual level. And I know as sort of baseline assessments also, we often sort of measure zinc and selenium and vitamin D levels and etc. But I've never seen any evidence. That doesn't mean there's no validity. I just think it hasn't been properly evaluated in terms of alternative sort of therapy. So I'm not sort of poo-pooing it at all. I think we need to go through an individual sort of approach at the moment, and sometimes having a range of vitamin supplementation is important, and I generally support that sort of approach at an individual level, but at the same time saying, look, we really don't know how much impact that this will have in terms of your long COVID symptomatology.
Thanks for that. And a question from me as well. With obviously the people who've been hospitalised with long COVID, we've seen at our end that they're much more likely to end up with ongoing symptoms and for quite some months afterwards. But we also, as per the slides that you showed us, have also seen our patients who've had very mild symptoms develop ongoing fatigue in particular. Is there a version of long COVID as well where people are getting mild symptoms, seem to be fairly well, and then develop fatigue and shortness of breath, or are we much more likely to be needing to look for other possibilities that are causing that type of pattern?
Yeah, so in my experience, most people with long COVID never fully recovered from the acute illness. They have some persistence of symptoms, particularly fatigue. So you know yourself, when you get sort of a severe sort of dose of any respiratory viral infection, you feel pretty fatigued for a few days, and it's a common sort of component. But the patients with long COVID don't tend to get back to full health. Look, occasionally can happen, but when you sort of really drill down and talk to them, they generally say they never recovered from their acute illness. So if I had a patient that had acute COVID, was well for 3 or 4 weeks, and then suddenly got sort of severe ongoing dyspnea and fatigue, I'd be thinking of other things. It doesn't mean that you exclude sort of post-COVID illness. And I talked about thromboembolic disease. So people post-COVID illness can have thromboembolic disease. It does seem to be an increased sort of tendency. So you wouldn't want to sort of miss a pulmonary embolism, for example, that occurred several weeks post the acute sort of infection, which can happen.
Yeah, thank you. By the way, whilst I'm thinking of it, Sumitha and Justin, you're most welcome to unmute and open up your camera and join us officially on the panel. A couple of other really good questions come through. Are people with long COVID more or less likely to get COVID? Is it they do have long COVID?
That's a great question. Actually, I saw a patient today that had COVID back in September last year, developed long COVID symptoms, then got COVID again in January, just compounded the long COVID symptoms. So I don't know that long COVID is either protective or makes someone more vulnerable to reinfection with COVID. It's really about the circulating sort of strains. But we know that reinfection can occur. It doesn't seem to occur much in terms of Omicron subvariant reinfection, but I think a lot of people were infected with Delta and then have become reinfected with Omicron. So that's the main reinfections we see, or the original sort of strain, obviously, and Alpha. But the other sort of thing in terms of the interface, and I should probably mention this, but there's a lot of discussion about what about vaccination as well. So, if you've had Omicron, say you've been doubly vaccinated, you've got Omicron infection, so you've got pretty good sort of immunity in terms of hybrid immunity from reinfection or further infection. But do you have a third vaccination? Do you have your booster dose? And the information around the impact of vaccination on long COVID symptoms is not very clear. So not surprisingly, some people get better, some people stay the same, some people get worse. So because there had been a bit of a theory that if it was a remnant sort of antigen stimulation, that maybe if you got vaccinated for further vaccination, that could control that sort of antigen stimulation. But there haven't been good studies that have really evaluated that. So I generally advise patients if they've got long COVID and they've had, say, Omicron, to wait a few months, but then to have a booster sort of dose coming up to sort of winter, and not to miss out on the potential benefit of a booster.
Yeah, terrific. Okay. We have a question here from Dr. House in relation to inhaled steroids. And so we've certainly been increasingly using inhaled budesonide for acute COVID. There's people who are particularly symptomatic, and especially if they've got cardiorespiratory illness that's pre-existing. But for people with a persisting cough after their COVID infection, do we have evidence that inhaled corticosteroids are of help?
Yeah, it's a good question. If you look at the lung function testing, it's not a bronchospasm type sort of phenomenon that we're sort of dealing with in terms of the ongoing symptomatology. So I'm not sure that it would work in that sense, but I mean, as an anti-inflammatory, if there is some ongoing inflammation and some interstitial sort of disease, it seems like a reasonable approach to take. I mean, the downside in terms of side effects is pretty modest. So I actually think it would be, worth trialing in an individual patient that has some ongoing cough and some breathlessness. I think it's a reasonable way to go.
Mm-hmm.
Sumitha might have some input there. What do you think, Sumitha?
So I think I see a lot of patients with cough. I tend to get them to do a cough diary, because not all cough are just related to throat irritation and due to COVID. There's also an anxiety related cough. Once they start, they can't stop. And so when they have the cough diary and they write clearly down when they're having this excess cough and things, and then I get the speech pathologist to review the patient and have a bit of a plan how they can stop the cough and how they can do breathing exercises to improve their lung capacity, and also the vocal cord exercises. So that can enable them to have a better technique when the cough starts, immediately to control it. So that's what we do. And I have not been giving any steroids or cough syrup or anything for the patients. And that seemed to work, because in the follow-up, I do see that they have changed. And the other thing also, anosmia, people who have anosmia also have quite a lot of cough, which I've noticed in my practice. And so I get them to do olfactory retraining, which essentially is to getting them to smell for strong smells, which just come from one of the study, which has helped 2 of my patients, where they have to smell this particular scents like clove, eucalyptus, rose, and lemon. For 10 seconds, they have to smell morning and evening, and they got to do that for 4 weeks, and then slowly increase the other senses. That also has helped them to reduce the cough, because this anosmia is also related to the cough somehow. As you've already mentioned, COVID is so complex, and so we're just targeting every aspect, looking at their breathing, their endurance, the cough diary, the smell. And lately, almost with every patient, I'm noticing there is some form of anosmia, because they haven't smelled all the smells. When you go in deep, they do say they can't smell this particular scent, which they used to be used for 20 years. So things like that, or they smell things in a bit odd way. They don't smell the usual way. Smells a little bit funny, but they haven't completely lost it. Dysnosmia is what the term they use. And I haven't got that the official smell test where you have quite a lot of sense of smells you got to do. I just go with the patient, what they say, and get them to do a bit of diary, so they can think and they can understand where the issues are and which exactly is the problem, and then they come back and report to me, because I do a lot of follow-up for my patients. It's just part of rehab follow-up.
Oh, thank you for that, Sumitha. Dr. Hazelton would like to know, presumably there are no biomarkers to clarify and simplify diagnosis at this stage, is that right?
Yeah, I wish there was. It's a common sort of question. I mean, it's interesting. My main area of clinical medicine last 20 years has been hepatitis C, with an easy diagnostic test and even easier sort of curative therapy. With long COVID, it's so complex because we don't have simple diagnostic sort of tests, and it's a little bit like some of the autoimmune disorders that we sort of try and sort of diagnose. It ends up being a constellation of symptoms and some sort of markers and so forth. So we've been looking, as I said, at some of these cytokine sort of profiles, but even those are sort of, as I said, are often elevated in people post-COVID without long COVID symptoms. Then you look at the inflammatory markers, CRP and D-dimer can be elevated, but they can be elevated for a range of reasons. So unfortunately, at the moment, nothing. We're looking at some specific neurobiomarkers and looking at the relationship between those neurobiomarkers and neurocognitive impairment. So that may be, again, one sort of component. So I think, as I've sort of mentioned, that long COVID is several different disorders, and it may be that we need to develop specific sort of biomarkers for those sub-disorders rather than trying to sort of find some sort of overarching biomarker, which I think is going to be very unlikely.
Mm-hmm. And so really as GPs, when someone presents to us with a constellation of symptoms that have been going on for quite some time, we just have to tease out really from the history whether it seems to be related in duration or in sequence to the acute COVID infection, or in fact something that's separate.
Look, yeah, I think so. I think one of the keys is to exclude sort of the obvious. So if someone's fatigued, to exclude anemia, hyperthyroidism, etc. So those, chronic disorders that could cause similar symptomatology. And then to do, as I said, do some markers that may give you an idea about ongoing inflammation. So even a sort of mild to mildly elevated CRP or D-dimer tells you something's going on in terms of ongoing inflammatory response. So it's important to do those sort of markers as well.
It's Justin. There's certainly been a increase I've noticed from a clinic point of view of patients who have presented wanting, either a blood test that I can get, can I get, IgG, IgM, something similar to Q fever testing or something to that effect, and that is certainly some of the uncertainty around COVID as it is at the moment has certainly fueled and added a lot of the anxiety and the mental health components that you mentioned earlier on, Greg, that, where people, and as we come into winter and the normal flu season starts to rear its head, has certainly fueled a lot of those anxieties and mental health and the need to get answers and have I had it?
No. It's a very frustrating area. Just some other things to mention in terms of the baseline tests that we do. I tend to do CMV and EBV serology, IgM, IgG. There's some evidence that EBV reactivation may be related to long COVID. Some people do EBV PCRs. So, it's, again, just covering off a few sort of areas that to exclude in terms of the potential symptomatology. But at the end of all of that, you'll find that the majority of your patients, you won't know what is triggering their ongoing symptomatology. But you just have to be open about that. Then you have to sort of address the symptoms specifically. And I think the important areas are to provide support, to provide empathy. As Sumitha sort of outlined, I think what the patients are looking for is some ongoing sort of contact, and in the context of sort of rehabilitation, and not to be told that it's all in their head in terms of what they're experiencing in terms of this ongoing symptomatology. And look, that's not everything in terms of that support and empathy, but I think just the approach that you have for these patients is really, really important. That you come at it with an open mind, you investigate thoroughly to exclude things that could be addressed in terms of reversible sort of disorders, and then you're open about the fact that you don't know exactly what's sort of driving some of this ongoing symptomatology.
Thank you, and that's a nice segue into the couple of questions here, which are mainly service related, and Sumitha, I might direct these ones to you. Two separate questions. The first one is there a specific criteria for referral to rehab after long COVID diagnosis? And the second one is, from a physiotherapist perspective, is it worthwhile running a separate pulmonary rehab program for patients with long COVID due to the requirements for limiting the heart rate to 60% of maximum? Your thoughts around those two things, so the criteria for referral and also establishment of a separate pulmonary rehab program.
Yeah, sure. The criteria for referral, what I've done is I've been working closely with the integrated care team. So they were the ones who were doing the chronic care in the community. So the nurses already know the patients who are with COVID, and then they do a screening. The Yorkshire screening tool is what we use. And then they do the screening tool, and if they score in any one or two more than 5, then I am happy to accept the patient, but I still need a GP referral. So the chronic care team, they are pretty good at the moment, where they give a lot of education, just health coaching, and then they've got lots of my resources which they send off to the patient, and they watch the patient for a couple of weeks to see whether they are getting better. If not, then they refer the patients to me. So I have a separate clinic where I run for long COVID patients. And once I see them, I have a plan with the multidisciplinary team within whichever area they are, based on individual basis, negotiating with the local MPSs and things. And then again, the same team, chronic care and the community, follow those patients up. And if there's any issue, they bring the patient back to me, and we do case conference for these patients. So I haven't got any specific criteria except for the Yorkshire screening tool, which I use as a screening thing, so that I can keep track of the patients and also help me to have some kind of data. But a lot of the patients also get referred to me without the screening tool, directly from the GP. So I haven't got any specific thing, specific criteria. Happy to accept any patients. And a lot of the time, as Greg was telling, you just have to acknowledge it's not in the head, it's real. And when you explain and educate, they're all right. A lot of them don't need to follow up, just need to be heard because of what they faced in the community, and when they've gone to the health service, what's happened. So, and the fatigue doesn't go away for everybody. And most of my patients have still got fatigue, but I have to discharge them. I've discharged them. They improved, but they've learned to live a life with the fatigue. That's how I'm seeing at the moment. And they're not the person that they used to be. Unfortunately, that's what I'm noticing. The ones who are very high athletes and things, they've lost that ability. So again, it's still early. Maybe after a year, they might improve. I'm not sure. But so far, what I'm seeing is that they're not that same person that they used to be, especially from the fatigue levels. Now, for the physiotherapy question, it will be ideal to have a separate individualized program for these patients, because a lot of my patients who I've seen in my clinic, they're mild COVID, but they still have long COVID symptoms, and they do not want to go into the cardiopulmonary program because they are elderly people with home oxygen and very severe COPD patients. They don't want to sit in the same room with them. So a lot of them, even if referral goes through, they don't go. So ideally, an individualized program will be better, a pacing program to suit each and every person's endurance, because each and every one are different. Someone you can put them for 10 minutes in the treadmill, they're fine. Someone you leave them even for 30 seconds in the treadmill, they're gone. So we cannot class everybody into the same thing. It has to be individualized program for them, which a lot of the physios in the district are able to understand, and they do it. And I send an email when I see the patients. Straight away I send the email to that particular physio, and my letter goes regarding what I would like them to do. So far it's going all right. There's been hit and misses. In certain places there are no physio. Telehealth physio is what they're doing, and that is not ideal, but unfortunately the area that they are, we can't provide anything. And again, transport issues, all of these things are there.
Thanks, Sumitha. I think I just might just sort of qualify in terms of your service that you provide. That's specific to the Orange. The patient has to be a resident in the Orange district, isn't it? So
no, I'm providing for the entire district. That's not true. Only the allied health is that particular district, but patients I see for the whole district.
Terrific. Okay. So at the moment, in terms of sort of rehab, outpatient rehab physician services in the rest of the whole Western and Far West footprint, we're fairly limited there. But thank you, Sumitha, for that offer to be of assistance. And we've got a few more questions. We are just 1 minute past 8. But if people are happy to hang on for a few more minutes, there's some other really great questions that I think it'd be good to get your input, Greg and Sumitha, into. One of them is in terms of the cough, might that be related to the ACE receptor? Do we have any information about that?
Don't know. Sumitha?
The ones who I deal don't have are not on ACE receptors, the ones who've had cough. They're pretty young ones with no comorbidities at all.
Yep, and okay, yeah, and probably not medication related, but yeah, whether that's just the ACE receptor itself. Another question, is taste affected too? Are we seeing that with Omicron as much as in previous, with previous variants? A friend of Dr. Pryor's says coffee now tastes sour. And in fact, that's something I've read quite a lot about on the chat forums.
It's definitely
goes with the taste. Smell goes with the taste.
Yeah.
Yeah. Okay. And one more here. Whilst it appears that rest and individualized pharmacological interventions are the main treatments, could progressively increased activity levels and exercise graded carefully be a useful therapy adjunct? This is speaking from the viewpoint of a physiotherapist currently with acute COVID.
Yeah, look, I mean, graded exercise therapy has a bit of bad press in the sort of the chronic fatigue syndrome, ME sort of community, and there was a trial that looked at that has caused a lot of angst. And I think in long COVID, there's some hesitancy around that. I mean, there's no doubt that some people will do well by slowly increasing their sort of exercise capacity, but I think the message is certainly don't do that early on with significant sort of long COVID symptomatology. And if people are getting incredibly exhausted post-exercise, that is a bit of a concern. It's probably a sign to sort of step back, so to speak. But Sumitha probably has more input on that than me as well.
So yes, that's a very common thing that comes to my clinics. So what I essentially tell them is the paced exercise program, but I ask them to pace it at 10% less the capacity that what they're doing. So I just give them an example. So if you are able to walk up to 100 meters or 500 meters, and if you feel that you are getting a bit breathless at 100 meters or 500 meters, whatever your level is, then reduce it down and walk only up to 80 meters and see, are you getting breathless at 80 meters? If you're not getting breathless, continue 80 meters for the next 2 weeks and see how you go. Then your body gets used to that particular level of exercise tolerance, then gradually increase another 10 meters and see. I get them to do it very, very, very slowly, because if they go up, then once they hit once the heart rate starts going up and they become breathless, it takes a longer time for them to recover, and the next day they're not able to do any exercise. So it's extremely slow. It's not essentially, we don't call it graded, we call it paced, but it's even less than paced, where you bring it down, not 10, a little bit lower than 10%. So, and it's again case by case. Some people take it on board and they're doing it. Some people get extremely anxious. So yeah, that's generally seemed to work, and that's what also is accepted at the moment in the physio college as well regarding exercise. And the ones who have POTS and things, they need to go on tilt table. They have to be on tilt table regularly to improve that.
Mm-hmm. Okay, and final question before we wrap up. Our ability to refer quickly to a neurologist is very limited in our region. Is there anything that the patient can do to help with neurocognitive issues?
Neurocognitive is, sorry, great.
Look, it's an incredibly tough area. And I'm not aware of any specific interventions that have been shown to enhance recovery from neurocognitive impairment. So yeah, I think it's really important that people are thoroughly investigated. As I said, we do a lot of brain imaging and spectroscopy, and there's significant numbers of people that do have evidence of neuroinflammation. We're hoping that that will resolve slowly, but we're seeing some people, as I said, that have very long-standing neurocognitive impairment.
Thank you for that. It's now 8:06. We had better wrap up, but thank you so much, everybody, for your attendance tonight. Thank you, Greg. Thank you, Sumitha, and thank you, Justin, for your input, and particularly in the discussion. It's been really, really a pleasure to be able to ask these questions and have them answered directly. I will hand over to Katie now to wrap up.
Well, thank you all so much. Ai-Vee, you've pretty much done it. We really appreciate everyone's time tonight. There's just a QR code there. We really appreciate your feedback about the session tonight, and also any learnings you want moving forward, because obviously, as been discussed, this is an evolving situation. So please list any learning needs that you want us to work on to address in future sessions. Greg, Ai-Vee, Sumitha, Justin has had to leave, but thank you all so much for your time. We really appreciate it, and we look forward to talking with you all soon. Thank you all so much.
A pleasure.
Thank you.
Bye, everyone.
Thank you. Good night.